Hello everyone, welcome to today's Dentium Live Surgery. My name is Yong-Soo Kim, periodontist practicing implant dentistry in Korea. It's my great honor and privilege to participate as a moderator of this session. Briefly introducing today's surgeon, Dr. Jang is a very well-known periodontist in Korea. He's been trying to apply minimally invasive concept in implant surgery. He has lectured nationally and internationally about the topic of implant surgery. Dr. Jang and I work together, sharing same concept of minimalism in implant surgery over the years. Today, he's going to introduce his concept and expertise in implant surgery. Without further ado, let's dive into today's case preview. Here we have case preview. The title is Ultimate Drilling Protocol. As the name implies, useful and efficient drilling technique and strategy will be discussed in this session. Patient information. A 75-year-old female with a chief complaint of loose tooth on tooth number 26 and 27 and 36, hard to chew, with the past dental history of from the tooth number 13 to 17, implant-supported fixed restoration utilizing bright bone level system. And tooth number 36 was extracted 2 days before surgery. And patient has osteoporosis. So considering her age and condition, it's good to shorten surgical time and trauma. So that's the minimalism. So she's good candidate for minimalism for this surgical procedure today. So today's surgical plan is tooth number 26 and 27. So he's going to place 26 with bright tissue level 5.0, about 5.9, and 27 on 5.7 bright tissue level implant. And tooth number 36, 5.7 bright tissue level implant with digital cylinder connection. So here we have a preoperative X-ray of this patient. So from tooth number 13 to 17, she got implant-supported fixed restoration already, and with the panorex in the middle, she got cavitated tooth number 27, so tooth number 27 should be removed. And on the right side, the periapical X-ray, she got a broken distal root of tooth number 36. And here we have a preoperative clinical photograph of this patient, tooth number 36, recently extracted, and tooth number 26 and 27. So we can appreciate the root remnant on the tooth number 27. We can have a similar case with case number 1, immediate implant placement for the mandibular molar. So tooth number 46 was extracted due to severe periodontitis. And after extraction, a minimal buccal flap is raised, and using a Lindemann drill, we'll go over the drilling protocol again later. So from the mesial to the septal bone was prepped with Lindemann drill, and then moving on to the next drill, and placing a bright implant, getting good primary stability, and placing the collagenous bone graft material on the socket. And also he prefers to place on the buccal side between the flap and the buccal bone to try to compensate future remodeling of the bone. And healing abutment was connected and sutured. In similar case number 2, on the upper side of implant placement, so the osteotomy was done with DAS kit and osteotome lifting, An implant was placed, and collagenous bone was also placed and sutured. So here we have our treatment plan with this case. So treatment plan is placing immediate implant on tooth number 727 and placing dental implant on tooth number 26 on the healed ridge, and on the lower side, tooth number 36 will be placed in immediate implant placement with contour augmentation. So all these implants will be utilized with Dentium Bright tissue level implant system. So the idea on the upper side, on maxilla, to avoid sinus complication, and on the lower mandibular side, try to avoid nerve damage. So here we have a preoperative CT scan of this patient. So we placed virtual implant with the CT scan with this case, and we can have better view of this case. And here we have a very useful tip when drilling for the immediate placement. So in maxillary molar side, we prep with reverse triangular shape. So try not to move around on inside the socket, so get a very good, nice stability when we perform the osteotomy. And on the lower side, tooth number 36, we start from the Lindemann drill from the medial side to the septal bone to make a nest-shaped slot to get a better accessibility for the implant placement. On tip number 2, when we perform osteotomy on the healed ridge, use Lindemann drill for sufficient time. So make overall shape of the osteotomy with the Lindemann drill, and then make the final touch with the final drill about a couple of times. And tip number 3, that's his strategy when he performed the GBR, bone graft, after the implant placement. So contour augmentation and simple membrane application. That's what we call the strip technique. So minimal incision with the curved incision and minimal reflection was made. And then bone graft mixture, he prefers to collagenous bone graft material and placing membrane with the overlapped fashion and simply suture up the flap. Now he just started his surgery. Seems like he already made a crestal incision. And gently removing the root of tooth number 27. He's using a periosteal elevator to gently remove the root and try not to damage the septal bone. And then after that, he removed the granulation tissue on the socket. Now he's starting with the Lindemann drill on the tooth number 27, I think. Yeah, he started with the tooth number 27, and he's making a reverse triangular shape at the socket. And then moving on to the next drill. So gently touching the final depth of the socket, and then retrieve the drill very quickly. Moving on to the next drill, gently. And he also preferred to utilize the bimanual application, so he always used both hands to get a good stability and preciseness. Checking the osteotomy, the parallel path of it. And now he's placing the implant on tooth number 27, on 70 RPM and 50 Newton per centimeter is the guided recommendation for the implant. With the hand wrench, is finishing the placement, getting very nice primary stability. And with the periosteal elevator, just gently reflecting a flap a little bit. Now it's time for the second implant placement. So he's getting a Lindemann drill. So in that case, he also prefers to move the Lindemann drill from buccal palatally a little bit. Tried not to make any fenestration on the buccal side. So try to get a better preciseness of the drill. And with drill extension, he's doing one more time. And moving on to the next drill, with both hands gently doing his osteotomy. And then next drill. And then next. Then now his implant is placed. With the hand wrench, he's finishing the placement, and you can appreciate also very nice primary stability is achieved. And removing the mount. And then connecting digital abutment. He's adjusting the position of tooth number 27 a little bit, and still can get a good primary stability, maintaining a good primary stability. And check the path with the photometer again. And then removing the mount. And connecting the digital abutment again. And check the path again to make sure, and try to bite the patient. Okay. And then removing the plastic cap and checking the path again. I think he's already finished the placement on the upper side, and moving on to the lower, tooth number 36. He's very quick. Gently making a crystal incision with the number 12 blade. And then starting with the Lindemann drill, as I mentioned, the similar fashion that I mentioned at the tip of the drilling protocol with Dr. Jang. Moving on to the next drill, gently touching the final depth and retrieve it. Always with 2 hands. Next drill. And then now he's placing 5.7 bright tissue level implant. And with hand wrench, also getting very nice primary stability. Removing the mount. And connecting the digital abutment. And check the bite of the patient, whether it can. He just removed the digital abutment and readjust the implant path one more time. considering the emergence profile, he's placing slightly deeper than he just placed before. And then connecting the abutment again and checking the bite. So it seems like he's already finished his placement. Now it's time for the graft. So it's pretty quick. Let's let him take it easy and take his time. Okay, so he's going to start with the lower side, tooth number 36, bone augmentation. So with the periosteal elevator, just gently reflecting the flap a little bit. So it's always beneficial to reflect the flap gently and gradually, little by little, not just one, quick way of all the way down to the mucogingival junction. So his strategy is making the flap to hold the graft better and with minimal incision and minimal reflection. So now he's placing the xenograft material, particulated bone graft material on the buccal side and the socket area. And one more figure 8 suture is placed on the tooth number 26. Making sure that the graft material is well secured by the flap. It's putting another suture. Now, irrigation with saline. Checking the bite. The surgery is done. So it was very quick and efficient surgical procedure. Even 3 implant placement and bone graft was done within 30 minutes. So it's very quick and efficient procedure, I think. Now we have a post-operative clinical photograph of this patient. So on the left-hand side, we got tooth number 36, implant placement. It's well placed and well secured by the suture, and graft is well placed and nicely done. And on the right-hand side, we can appreciate tooth number 26 and 27. The implant placement was well done, and suture was well placed, and graft material is clean and well secured. So very well done. And we got a post-operative panoramic X-ray here. So he kept very nice parallelism of the path on the tooth number 26 and 27, and forgot to mention that he prefers to place, when he got two consecutive implant placement, he preferred to place tooth on the distal one first and then moving on to the medial one. That's why he placed tooth number 27 first and then moving on to the tooth number 26. And then tooth number 36 is also well placed, and considering the emergence profile, it's well done with the depth of the implant placement. So 3 implant placement in a quick fashion and safe and a convenient way. That's the minimalism of his concept of the procedure. Here we got a question, Q&A. How many millimeters of implants are generally placed in the posterior region? So the question is, what size of implants are generally used in the posterior region? So in general, in the past, looking at the literature, 5.10 is the guideline for placing dental implant placement. But now, with the consensus of Dentium community and the 4.5 by 7 is the standard of the implant size on the posterior region, and you can modify 4.0 to 9 by 9 if you can have a longer depth of the placement. And also, like this case, if you have immediate placement on other clinical condition, you can also place 5 by 7. That's also good for posterior region. So this is all for today's live surgery. Thank you for watching. And next live surgery will be 2023, November 3, 2023, Friday, Korea time at 7 p.m. Thank you. 감사합니다.